I have no conflicts of interest to report, and in this talk, I won't be speaking on much of the specific data from our study, but we will be presenting on Tuesday from 4:30 to 6, and there'll be lots of other interesting presentations during that session around this topic. So what I'm going to focus on now is these warnings that came out on May 18th, 2018 from WHO, FDA, EMA, and I'm going to spend a lot of time discussing how did we get here, because I think that helps inform the implications and what do we do with this information. So for people that don't work in pregnancy safety, and just work in HIV, it's sometimes not obvious, but the magnitude of antiretroviral exposures in pregnancy, particularly in countries with a high HIV prevalence, outweighs that seen for any other drug in history. For example, in Botswana, where I work, 25 of all births in the country are exposed to an antiretroviral drug. So the magnitude of these exposures is really new and different. And of course, this is a good thing. It's been a major public health success to provide ART to pregnant women, and we've seen a 75% decrease in new pediatric HIV infections since 2000, mostly because of the rollout of 3-drug ART in pregnancy. So, of course, 3-drug ART is critical in pregnancy to prevent mother-to-child transmission, for maternal health, and as decreasing transmission risk to uninfected partners. So as it's critical, as it's needed, we then have to ask the questions, is it safe in pregnancy? And specifically, which ART regimen is the safest? Although most people kind of automatically think of birth defects, when I talk about safety in pregnancy, I think about a lot of different outcomes beyond birth defects, including miscarriage and stillbirth, preterm delivery, birth weight, longer-term pediatric outcomes, as well as maternal effects such as gestational hypertension, preeclampsia, and anemia. So do we know if ART is safe in pregnancy by 2018? We should, because women of reproductive age make up almost half of the worldwide population of HIV-infected people. This is not exactly a special population. And more than 2 million HIV-infected women every year become pregnant. But when we look at what we know, it's very little. With 31 currently approved antiretrovirals, there is really limited data on the safety during pregnancy. And the only ARV with an FDA indication for pregnancy currently of these 31 is AZT. And this is not entirely the fault of anybody, because it's challenging to study drug safety in pregnancy. And this applies to all drugs and not just antiretrovirals. There's a lack of inclusion of pregnant women in clinical trials during drug development. Of course, you don't want to expose a fetus to a drug when you don't know what could happen. But then what we do after that is mostly post-marketing surveillance, which is a voluntary report by healthcare providers. It's not systematic, it doesn't usually have a denominator, and it tends to get reports of severe effects rather than an overall picture of what's going on. And then when we rely on pregnancy safety data from this kind of observational data before any randomized control trials could be done in pregnant women, it actually requires the use of these medications in pregnancy before data on safety, which is really a chicken and egg problem for a pregnant woman and their provider. You're kind of hoping somewhere in the world pregnant women are getting onto your drug. And another challenge, which is more specific to HIV and antiretrovirals, is that the majority of exposures in pregnancy in the world occur in countries where systematic surveillance for safety of drugs in pregnancy has been lacking. And the countries you see here highlighted are the where about 90% of HIV-infected pregnant women live, mostly sub-Saharan Africa and India. So one place where systematic surveillance has started to be done is Botswana. And although some people hear this data and think, can we believe anything from Botswana, it's actually more of an ideal setting than you might imagine to do this kind of work. We really have the ability to capture outcomes quite well. Women bring their maternity card, which has their entire medical record from pregnancy to delivery, and in Botswana, more than 99% of women bring this card with them. Also, unlike surrounding countries, more than 95% of women in Botswana actually deliver in a healthcare facility. And we don't really have prenatal diagnosis and termination of pregnancy, so we do see most of the outcomes. And then, as I mentioned earlier, there's also a very large number of exposures, which HIV prevalence in pregnancy of about 25%. Botswana has done a fantastic job of getting ART to their pregnant population, and more than 90% of women are on ART at delivery. And also because how they've rolled out their guidelines, there's multiple antiretroviral regimens in use concurrently, which is not true of a lot of other high-burden countries. And more than half of women start their regimens before conception. So we have undertaken several birth outcomes studies in Botswana. The one that's currently going on where this data came from is called the Tsepamo study, and it started in 2014, funded by NICHD. In 2014, we had two primary aims for the study, which were to evaluate adverse birth outcomes by HIV status and ART regimen, and secondly, to determine if there was an increased risk of neural tube defects among infants exposed to efavirenz from conception. And in case it's not clear, I think it's important to know why we were interested in efavirenz and neural tube defects at the time, and why we were focused on medications that started prior to conception. So I think probably many people here will remember, but for many years, efavirenz was avoided in women of reproductive age. It was FDA category D in the United States. And this was based on animal data in early clinical studies, where 3 of 20 infant monkeys who had been exposed to efavirenz from conception had severe CNS defects. But by 2010, 2011, TDF-FTC efavirenz was really seen as the best available ART. It was the only one pill once a day available in most places at this time, and there was a goal to harmonize ART for all adults and pregnant women because that's so much easier to roll out. And in 2011, a meta-analysis was published of about 1,400 women in 21 different studies who fell pregnant while taking their efavirenz. And this ruled out about a 4-fold increased risk for neural tube defects. So starting that year and the year later, there was a really rapid rollout of TDF-FTC efavirenz as first-line ART in most of the high-burden countries. And so we were doing this study to make sure there wasn't actually a neural tube defect effect, because it wasn't totally clear at the time. And then why did we focus just on medications started prior to conception? I think usually we think about the first trimester for teratogens, and that's because between about week 3 and 8 and sort of up to 12 is really the most active period for organogenesis. The organs are forming, and this is when the fetus is most at risk for developing a birth defect. But neural tube defects are a specific time period during the first trimester. And the risk period for neural tube defects is actually over about 28 days after conception, so very, very early in pregnancy. And that's when the neural tube actually closes. So I'm not going to go through this, but depending on where the defect of the closure is, that is what determines what the phenotype of the neural tube defect is. And phenotypes can include anencephaly, cranioschisis, open spina bifida, closed spina bifida. So when we are looking specifically for neural tube defects in efavirenz, the risk period for these neural tube defects is really often before a woman even knows she's pregnant. So medications of concern are almost always started prior to conception and continued through the first trimester. So getting back to the study, Tsepamo, it takes place at 8 of the largest maternity wards in Botswana and covers about 45% of the total births in the country. We had a planned enrollment of 94,000 over 4 years, which was based on an ability to rule out a twofold increase in neural tube defects among women on efavirenz, and we predicted a 0.1% prevalence of neural tube defects. Our study design is pretty simple. We have research assistants who abstract data from obstetric cards for all consecutive in-hospital deliveries, including live births, stillbirths, HIV positive, HIV negative. And then when midwives identify an infant with a congenital abnormality, they contact our research assistant who consents the mother for a photo of the abnormality, which is then reviewed by an expert in Boston for diagnosis. But it is very important to know that our surveillance has limitations because we are only looking for abnormalities detected at the surface exam at birth. We can't see cardiac defects, which are common, or other internal organ defects. And we've also been very careful to exclude defects that aren't consistently and reliably evaluated during every infant surface exam, such as undescended testes, an isolated cleft palate, or hip dysplasia. Tsepamo has been ongoing now for almost 4 years and has already produced some interesting data on the safety of antiretrovirals in pregnancy. A planned 2-year analysis looked at 5 of the most common ART regimens at conception in Botswana, which you can see here. And the key finding was that TDF-FTC efavirenz in the first column had far less adverse birth outcomes and severe adverse birth outcomes compared to the nevirapine and the lopinavir-ritonavir-based regimens. And so the light bars there are any adverse, which includes a stillbirth, a preterm, an SGA, or a neonatal death. And the severe includes a stillbirth, a very preterm, less than 32 weeks, very small for gestational age, less than 1,500 grams, and neonatal death. And not only was it statistically significant, but the magnitude of differences is really huge. 36% compared to 47, 48%, and 12% compared to 18, 20%. These are very large differences, especially when you think of the whole population. And then, as Tsepamo was ongoing in mid-2016, Botswana decided to change their first-line ART from TDF-FTC efavirenz to TDF-FTC dolutegravir. And they were really the first country to include dolutegravir as first-line for everyone, including pregnant women. And this allowed us to provide the first data on the safety of dolutegravir started during pregnancy. And we recently published that data showing that compared to women who started efavirenz during pregnancy, there was no increase in adverse or severe birth outcomes. In this analysis, there were also 280 women who started dolutegravir in the first trimester with no increased risk of birth defects, although the vast majority of those started after 8 weeks. So if you think about what our surveillance is doing, we were quickly able to turn around data on dolutegravir started during pregnancy, but it takes a lot longer to accrue the data on births to women who started dolutegravir prior to conception, because they have to start ART, then become pregnant, and then deliver their baby. So you can see here in the graph that from the time dolutegravir was rolled out, it took about 9 or 10 months to start accruing. And by May of this year, we had accrued 426 births to women on dolutegravir at conception. And it was this group where we saw the neural tube defect signal, where 4 of those 426 births had a neural tube defect with a prevalence of 0.94%. This was about 9 times higher than we had originally expected, and about 9 times higher than all of our other comparator groups, HIV negatives, women on other ART at conception, women who started dolutegravir during pregnancy. And this was statistically significant. So first we reported it to Botswana, to the Ministry of Health, and then to WHO, VIV, and NICHD, which led to all of these warnings. But I think it's important, and I try to keep saying this is really an early signal for dolutegravir at conception and neural tube defects. This requires more data to confirm or refute. We only have 4 cases. The absolute differences are very small. And so what we are doing in our study is it's ongoing, and by mid-2019, probably the end of March, we expect to have data on about 1,200 births exposed to dolutegravir, and we'll do another analysis at that time. Unfortunately, as you may have gotten from the beginning of my study, there's really not other comparable data from other parts of the world at the moment to help confirm or refute. There's a little bit of data from low prevalence settings, like the UK and France, but they just don't have many in their system. And then other high prevalence settings either aren't using dolutegravir yet, or Brazil and Kenya are working on setting up systems to help us get more data in different settings. So while it's a little bit hard to be patient for everyone while the data collection continues, I think there are some implications now, and there will be different implications when we know more in a year or two. But I think it's important for people to remember, and maybe this is obvious, but this is not an issue about pregnant women. It's really an issue for all women of reproductive potential. This is when you are on a medication as a woman and could get pregnant, which makes it harder. Because how do you approach ART now with women of reproductive age? There's so many different scenarios you have to deal with. You can deal with women who are already on dolutegravir, and maybe they're presenting to you as a follow-up, or maybe they're presenting to you already pregnant, and those are two different groups. Or you may get to women who present to initiate ART while not pregnant, and those who present to initiate ART while pregnant. And then there's a whole group of HIV uninfected women who may need post-exposure prophylaxis for either occupational or sexual exposures or after an assault. And you really have to kind of think about the risks and benefits in all of these groups quite differently. And I think, unfortunately, a one-size-fits-all approach, given where we are with this uncertainty, is unlikely to work. Harmonization of a single regimen for all adults, including pregnant women and all women, is no longer obvious as it was probably just a couple of months ago. And that's really too bad, because that harmonization has been one of the key ways that the world has gotten so many more people on ART and suppressed. But the risks are different. So if you decide, I'm just going to go with dolutegravir for everyone, obviously you risk neural tube defects in women of reproductive age. But if you think, well, I'll just avoid dolutegravir and maybe use efavirenz only, you might risk more ART failure, more side effects. Some people have suggested efavirenz for women and dolutegravir for men, but there's major issues of inequity if this is the approach and men get a superior regimen. Some people want to use raltegravir, but there is no similar data on raltegravir. There is no data on birth defects with raltegravir at conception. There is no outcomes data on miscarriage and stillbirth and preterm. And we have no idea at this point if this could be a class effect, if it's even something at all. And then unfortunately, there's also no similar data on modern PIs that are good regimens, darunavir and atazanavir. And there's lots of data that lopinavir, ritonavir is associated with adverse birth outcomes, particularly preterm birth, and that's from both randomized and observational studies. So an individual approach makes sense, but it also has a lot of barriers. First of all, the risk, when you're trying to explain it to a patient, we still have no idea what the true risk is here. This is still in very much a gray zone. It's very difficult to predict the benefit of dolutegravir versus efavirenz in an individual when you're starting a regimen. The other very difficult thing is that at least 50% of pregnancies around the world are unplanned, so it's hard to sort out, do you want a pregnant, do you not want a pregnancy, where are we with that? And complicating that is that contraceptive access is very poor in many settings with high HIV prevalence, especially very effective long-acting contraception. Then settings differ about whether they can provide an accurate prenatal diagnosis of a neural tube defect and then access to termination of pregnancy. And accurate pregnancy dating even varies significantly across settings. And finally, the healthcare encounter is not always sufficient and effective for a full discussion of risks and benefits, depending on the setting and the amount of time allowed and who's doing that and what they've been taught. So of course, though, given all these difficulties with either a public health or an individual approach, people have to do things, countries have to decide. And so this is just two examples of strategies that countries are using. Botswana updated their guidelines and have basically decided dolutegravir should be used in women not planning a pregnancy with effective contraception, efavirenz for those wanting to get pregnant, probably efavirenz for pregnant women, although that's still up for debate. And they say women already on dolutegravir should speak to their healthcare provider, which is a very gray zone. In contrast, DHHS in the US has given a bit more specific, that they would recommend pregnancy testing prior to ART, dolutegravir okay for women not desiring a pregnancy. If women want a pregnancy or are not on effective contraception, they recommend valtegravir, atazanavir, darunavir, efavirenz, or rilpivirine-based ART. And they specifically say that women less than 8 weeks pregnant, where they would be at risk for neural tube defects, should not start DTG. But if they're less than 8 weeks pregnant and already on DTG, they should talk to their healthcare provider and maybe be switched off, while women more than 8 weeks pregnant can start or stay on dolutegravir-based ART. So I don't think I can give any kind of definitive conclusions about the implications of this, unfortunately, but I hope you take away that the study of the safety of antiretrovirals in pregnancy has not been a priority and really needs to be. Dolutegravir is not the last ART that's going to be rolled out. It's not the last HIV strategy, and these things need to be in place when drugs are rolled out. Tsepamo, our study has previously shown that dolutegravir was as safe as efavirenz when started during pregnancy. This signal is very preliminary, needs more data to confirm or refute. And basically that the signal has put providers, country programs, and women living with HIV in a difficult position in decisions regarding ART treatment. And we have a really amazing study team on the ground in Botswana who I need to thank.